Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. Today we're going to move on with the digestive system. In the last episode, we got as far as the esophagus and swallowing. So today we're going to pick it up with the stomach. There's a lot going on in the stomach, so we'll see how far we get. I'm very excited for this episode because recently I talked to someone you may have seen on Instagram, TikTok, or YouTube, where she posts instructional anatomy videos, quizzes, and helpful memory hacks called mnemonics that students can use to help remember a lot of the anatomical structures that are going to be on your exams. She goes by my.anatomy.teacher on Instagram and TikTok. Her name is Dr. Jill, and I love what she is doing on social media to help students out. So I'm sharing our conversation with you all right now. So please, welcome to the show, Instagram and TikTok's My Anatomy teacher, Dr. Jill. Okay, welcome Dr. Jill, or as most people know from Instagram and TikTok, My Anatomy teacher. Thank you so much for taking time to come on the podcast.
Thank you so much for having me. I'm happy to be here.
Well, I'm really happy to have you. I've been watching your Instagram account for quite some time, and I think what you're doing is really, really good for students. So if you don't mind, for those listeners who don't know who you are, if you could just tell us a little bit about yourself and what you do.
Absolutely. Well, thank you, first and foremost, for watching my videos. That always makes me happy to hear when they're received well. And my background, I have my doctorate in chiropractic, and that's really where I fell in love with anatomy and physiology, was in chiropractic school and getting involved in tutoring in those subjects pretty early on. And I went into private practice full time initially, but I knew that I loved teaching. So I was teaching an evening anatomy class just for the love of it. And it was really then that I realized that I just had this passion for being in the classroom and for educating in the topics of anatomy and physiology. So I transitioned into teaching anatomy and physiology full time. And as I was moving into that full time teaching role, I noticed how intimidating the topic could be for a lot of students, especially when it was their first time taking a college anatomy and physiology class. And I wanted to show students that it can be not only an incredibly rewarding subject to learn, but also one that is accessible because these topics are applicable immediately in terms of your own body, in terms of clinical applications. So when I started my social media platform, it really was to just provide these little tips and tricks and simplifying concepts in a way that gives students confidence in their ability to succeed in anatomy and physiology. Because I find when they increase that confidence just a little bit, especially early on, then it empowers them to really kind of take hold of the topic as a whole and really learn it in a way that's providing a foundation for growing into whatever career trajectory they're heading towards.
Yeah, that's great. We have a very similar background story. I was the same. I went to chiropractic school, finished there, was practicing, and started teaching at night. And it's similar. I tutored when I was in school because I came into chiropractic school with an exercise physiology degree. So I was a little ahead of the game in a lot of the classes compared to some other students, and got into the tutoring and teaching review classes, and same exact situation. Within a year or two of graduating, I think I started teaching. And I never looked back. I loved it. I started teaching, and then within a few years, I was hired full-time tenure track, and then that's been 23 years now. So
That's
it's
awesome.
been quite some time, but I do really love it. So when it comes to your videos, I have some favorites, and I'm still a little curious as to what got you into a medical profession, what got you into being interested in how the human body works.
Yeah, I think that I always had an interest in the healthcare field in general. That was something pretty early on that I knew I wanted to eventually end up in some healthcare related field. And I think that came from I loved athletics when I was young, and I saw pretty early on how progressing towards being a higher level athlete, understanding the body is really important towards that. And not only physiologically, how, taking care of your musculature and understanding even basics of certain exercises, but also nutrition. And I ended up running, so I ran cross country and track through high school and was fortunate to be able to run through my undergrad as well. So I ran D1 cross country and track, and that really just furthered my interest in the human body from a bit of a kind of a selfish viewpoint at times, because I was just trying to learn how to better take care of myself to be the best athlete I could be. But unfortunately, but in retrospect, I guess learning a lot, I had a lot of injuries towards the end of my college career within track and cross country, and it was really in that time frame that I really dove in even more so into how I wanted my career to be able to help others in the way that I needed when I was going through a number of these injury cycles. So that's what really drew me towards the chiropractic field specifically. Was I really liked the conservative approach to patient care and really investigating the root cause of musculoskeletal issues and injuries and being able to address those and prevent future injuries. So a lot of that led me towards the chiropractic profession. That first year of chiropractic school, when the course load is so heavy in the anatomy, physiology, biochemistry, neuroanatomy, all of those courses, most of my classmates were like, got to get through this type of thing. But I loved that. I loved those classes. I absolutely saw an immense value in understanding that foundational knowledge, not only in allowing you to be the absolute best, clinician that you could be eventually, but also in just empowering you to understand different pathophysiology and understanding different mechanisms of injury really to its core, because you understand the foundation of how the body works. So I think, kind of coming full circle to how I love teaching so much, it's because now on this end of it, I get to be at the start of a lot of these students' progression towards their healthcare fields that they're working towards, in being this foundational course that if they know anatomy and physiology really well, they are absolutely going to do much better within the clinical classes that they're moving into, but also making them better clinical providers in whatever healthcare profession that they're moving into. And most of my students are in accelerated healthcare programs, whether that's pre-nursing, radiology, physical therapy. Those are a lot of the students that I teach. So I just see a huge value in that. And I know that the instructors I had who were teaching me the anatomy, physiology, and those core classes are ones that I still look back to. They absolutely provided so much value to the trajectory of my educational path and career to this point.
Yeah, I agree. I think having that clinical background really helps with the students we have in A&P because, like you said, I also have the same group: nurses, radiology, PT, OT, PAs. This is a lot of my students, and having that
Hmm.
clinical spin on A&P, even though it's a preclinical course, I think really
Hmm.
keeps them interested. They get a little light at the end of the tunnel a lot because that's
Hmm.
what they want to do. So when it comes to your videos, I do want to talk about that because I have some favorites of
Yeah.
your videos. And there's some things that I like in terms of what you do. Like one, you often do like a little short quiz where
Hmm.
you'll hold up a model, like, and they're the same models that we all use, so that's kind of nice. So
Hmm.
you'll hold up an anatomical model and you'll say, "Can you tell me the structures in this part of the ear, for example?" And then you'll
Hmm.
give a beat or two and then give it, which is really nice for students to kind of check their ability to recall because that's a really
Hmm.
important technique and skill for students right now. If you go back a few episodes, you'll hear me talk to someone about learning science, and they talk about all these things that students need to be
Hmm.
doing to actually be successful. And then you also use a lot of mnemonic devices, little tricks for
Hmm.
students to memorize the things that are really hard to memorize, like cranial nerves or carpal bones or things like that. So I
Hmm.
really like those. So let me ask you this. What would you say is some of your most effective mnemonic devices for your students?
That's a great question. Well, when I introduce mnemonics within class, let's say if I'm lecturing on a specific topic, a lot of times I will introduce mnemonics, and some students like using them more than others. So I'm never like, you have to memorize this mnemonic. If it's helpful for students to, remember the starting letter for the carpal bones or whatever the mnemonic correlates with, then that's great. But there are a couple of specific topics that I highly encourage them to use mnemonics just because there is so much inherent value in just these catchy little phrases that might be more likely to stick in your brain come the time of like the final exam in a couple months than maybe, just listing out all 12 cranial nerves off the top of your head at the, drop of a hat. So I would say that cranial nerves for sure is when I present like three common mnemonics that are utilized for cranial nerves and have them work in partners and say pick a mnemonic that you're going to memorize before even introducing the names of the cranial nerves, because most of my students are brand new to cranial nerves. It's the first time that they're being introduced to this list of 12 new names. So they pick one of the phrases, and I have them sit in partners and quiz themselves on the phrases. So they get familiar with the phrases first, so that that's just like they know these kind of weird but kind of catchy phrases. And then we move into the talking about the names. So basically, immediately they already know the starting letter, and that just provides them a good foundational starting point. So if they're using the on occasion our trusty truck acts funny, very good vehicle anyhow, that's like one of the most common ones that students like to use for the starting letter of the 12 cranial nerves. Then okay, we know the starting letter, now we can talk about the name of each. I also like with the cranial nerves how there's the kind of correlating mnemonic of telling whether or not the cranial nerve contains sensory fibers, motor fibers, or a combination of both. That was one that was really helpful to me, I know, when I was initially learning cranial nerves, because there's so much. I mean, it's a lot already to just memorize the names, but then when you're correlating, okay, we're learning the functions as well. You need to remember if, motor, sensory, both, all of these things. If that additional saying that could be correlated on top of the starting letter. You can, like, some say Mary Money, but my brother says big brains matter more. That's a very common one my students like to use. That gives you the starting letter: S for sensory, M for motor, B for both. And they already have a huge jump start on the memorization process for cranial nerves, even with just learning those couple of simple phrases that can be really effectively memorized within, 10 to 15 minutes. So that's really where I see huge value in mnemonics, is when they are they're they're not replacing the fact that you still have to learn the actual anatomical terms and you still have to spend the time with the material to do that. But they're helpful in just kind of triggering the memory, and also helpful in occasion where, you do have a multiple choice question and you can't remember the name of cranial nerve number 4, but you can remember that phrase and you're like, well, at least I know it starts with the letter T. And then trochlear is the only one that starts with the letter T out of the 4 multiple choice answers. So it can provide a lot of value in that regard as well.
Sometimes people will say that the mnemonics really kind of get in the way of the actual learning, but
Mm.
I feel like I used some when I was in school, and now I don't need them anymore. And the main reason is because if these are things that for you will come up over and over again, eventually the mnemonic will lead to you no longer needing it. So I think it's okay. Now, I want to ask you real quick, can you repeat the one about the truck?
Yes, it's on occasion our trusty truck acts funny. Very good vehicle anyhow. Yeah.
Okay, got it. All right, so that's a good one. Maybe what I'll do is I'll post on Instagram or something. But those
Yeah.
those are really good. So I noticed that you had a video that I really liked that was a quiz video, and it
Hmm.
was for muscles of facial expression where you had a
Mm.
filter on your face. How did you get that? Is that just something that was in Instagram or TikTok?
Yeah, it was actually in the TikTok filter. So I was curious because I was like, I wonder what type of anatomy filter options are within this, TikTok filter feed or whatever you call it. But yeah, when I saw the muscles of facial expression, I'm like, oh, this is a little bit weird. But I mean, I kind of liked how it was like it showed anatomically accurate enough in correlating how my face was even moving when I was talking to be able to, create a quiz on what some of those muscles of facial expression are. And I'm like, how cool would that be if there were, more filters like this for holding up a palmar view of the hand? And I know there's anatomy apps out there and lots of anatomy resources that have kind of that set up to work through. But it was cool from a social media platform standpoint to have that filter and be able to create that quiz right within the TikTok.
If you are listening and you haven't seen it, go to the Instagram account, which I'm going to post in the show notes. It's at my anatomy teacher. And I think you've got some periods in there, like my.anatomy.teacher on Instagram
Yes.
and TikTok. And look for that one at least, because that was a really cool one with the
Thank you.
facial muscles all on Dr. Jill's face. So that was pretty neat. So, could you let the listeners know where they can find you on social media and what else you do? I do notice that also on your account, you put out that you do some tutoring and things like
Mhm.
that. That looks like there's some other resources that you offer in addition to the social media pages.
Absolutely. I am most active on TikTok and Instagram at my anatomy teacher, yes, with a period after each of those words. So my dot anatomy dot teacher. And then I do have a YouTube page as well that's mostly the same content, but I'm in the works of making a couple of longer form videos too, but that's kind of in the process of being formed still. I do offer some one-on-one tutoring that is linked within the bio of my accounts on both Instagram and TikTok. In addition to, I do have a couple of study guide resources and practice tests and things that are linked from the link in my bio as well. So I love interacting with students and really the purpose of my page is to provide educational value and to make taking an anatomy and physiology course less stressful because it's already a lot of material you have to learn. And I don't think that stress needs to just be on top of all that for no reason. So I really try to remove as much of that stress and make it a fun experience to learn anatomy. So feel free to, send me a message on any of those platforms as well, or my email's linked as well. And I'd love to connect.
Well, thank you so much. I say on this podcast all the time, this is about getting a B or better in A&P because that's what the nursing schools are requiring right now. So
Mhm.
I think that what you're doing is going to help students get their B or better in A&P, and I really appreciate it. And I think you should just keep doing what you're doing because it's a lot of fun, and I think it's really valuable from a learning standpoint for students.
Well, thank you so much. That means a lot, and I definitely have that intention and hope in mind in creating the content that I am. So I'm looking forward to continuing to do so.
Great. Is there anything else you want to share with listeners?
I don't think so. I just want to thank you again for having me on. It's been an absolute pleasure to be here, and I appreciate being asked.
Well, thank you so much for taking the time to join me. I love getting to talk to people and especially people in the field, whether it's healthcare providers or authors or professors or people doing this on social media. Whatever we can get out to the listeners, I think is going to be beneficial. So thank you once again. I really appreciate you taking the time.
Thank you. Thank you for all you do as well.
Okay, that was a lot of fun. There are some instructors out there who are really going the extra mile when it comes to fostering student success, and Dr. Jill is certainly one of them. I can't thank her enough for joining me. Let's take a second to review two of the mnemonics that Dr. Jill mentioned. The cranial nerve mnemonic that helps you remember their names in order from 1 to 12 is on occasion, our trusty truck acts funny. Very good vehicle anyhow. The mnemonic that helps you remember if their fibers function as mainly sensory, motor, or both is some say marry money, but my brother says big brains matter more. So using those, we can list the cranial nerves and their fibers as olfactory, which is sensory, optic, sensory, oculomotor, motor, trochlear, motor, trigeminal, both, abducens, motor, facial, both, vestibulocochlear, sensory, glossopharyngeal, both, vagus both, accessory, motor, and hypoglossal motor. I put links to Dr. Jill's social media accounts in the show notes for this episode, and I tagged her on an Instagram post I made to go along with this episode. Remember, you can find her on Instagram and TikTok as my.anatomy.teacher. Now let's get back into the digestive system. Okay, so now that we've talked about the esophagus and swallowing, it's time to move on to the stomach. The stomach is the beginning of the gastrointestinal tract, the region of the digestive tract where absorption begins. The prefix gastro refers to the stomach. So let's discuss the anatomy first. The stomach is a relatively large organ and it's shaped like the letter J. It's mostly on the left side of the midline of your body, and it has a really big cavity so that you can eat an entire meal and it has somewhere to go. We mentioned last episode that the stomach has a unique wall in that the muscularis externa has 3 layers of smooth muscle, not 2. In addition to the typical circular and longitudinal layers, there's an oblique layer. That oblique layer provides another contraction pattern to help mix up contents of the bolus so that we can mechanically break it up and facilitate its exposure to the stomach's digestive secretions. The stomach's divided up into 4 regions. We mentioned the cardia in the previous episode. That is the region the esophagus empties into. The fundus, that's the region superior and lateral to the cardia. The body is the largest portion and is found inferior to the cardia and fundus. And finally, the body of the stomach bottlenecks into a narrow tunnel called the pyloric region. Think of the pyloric region as a funnel through which chyme leaves the stomach and enters the first part of the small intestine called the duodenum. The proximal part of the pyloric region is the wide part of the funnel, and it's called the antrum. The narrow part of the funnel is called the pyloric canal. The hole between the pyloric region and the duodenum is the pyloric orifice, or pylorus, and is regulated by a circular band of smooth muscle called the pyloric sphincter. The large convexity of the stomach facing inferolaterally is called the greater curvature. That is an attachment point for a fatty fold of peritoneum called the greater omentum. That greater omentum starts at the greater curvature, hangs down anterior to the abdominal cavity, then folds back up and attaches to the transverse colon of the large intestine. It's continuous with the serosa of each of these organs, the stomach and the transverse colon. The smaller concavity of the stomach, which faces superiormedially, is called the lesser curvature. Attached to that is a folded peritoneum called the lesser omentum. The lesser omentum extends from the liver to the stomach and the duodenum and is divided up into 2 parts. The part attached to the stomach is called the hepatogastric ligament, and the part attached to the duodenum is called the hepatoduodenal ligament. When the stomach is empty, its internal surface is wrinkled into gastric folds called rugae. When the stomach is full, it expands and the gastric folds unfold, flattening out to accommodate the new contents that we just put in the stomach. When the smooth muscle of the stomach is stretched by the presence of food, they initially contract, but after some time, they relax. This stretch-relax response allows the stomach to remain expanded to accommodate all the food and fluids that we swallow. Throughout the mucosa of the stomach lining, we see deep crevices called gastric pits. At the bottom of each gastric pit are gastric glands, which secrete gastric juice, which is then squeezed into the stomach cavity with the help of contractions of the muscularis mucosae. There are 5 different cells in those gastric glands. 4 of them are exocrine cells that secrete their products into the stomach cavity, contributing to the 3 liters of gastric juice that contributes to digestion. They are the surface mucus cells, the mucus neck cells, chief cells, and parietal cells. The surface mucus cells and mucus neck cells differ in location and slightly in the mucin they secrete. The surface mucus cells line the surface of the stomach cavity and the superficial part of the gastric pits, whereas the mucus neck cells are inside the gastric pits. The mucin they produce combines with water to produce a mucus coating of the stomach cavity. The mucus protects the stomach wall from being damaged by the acid and digestive enzymes of gastric juice. It also lubricates the wall to prevent injury from the movement of gastric contents. The parietal cells of the gastric glands secrete intrinsic factor, which is a glycoprotein necessary for the absorption of vitamin B12. Vitamin B12 is essential for normal erythropoiesis. A lack of vitamin B12 absorption causes a dangerous erythrocyte deficiency called pernicious anemia. Parietal cells also release hydrogen ions and chloride ions into the stomach cavity, which then bond to form the hydrochloric acid responsible for the low pH of gastric juice. Gastric juice is as acidic as 1.5 to 2.5 on the pH scale. The acidity of the gastric juice helps break down food, denature proteins, and activate other enzymes like pepsin, lingual lipase, and gastric lipase. The low pH also kills a lot of ingested microbes and their toxins. Chief cells secrete pepsinogen, which is the inactive zymogen of the protein-digesting enzyme pepsin. When pepsinogen comes in contact with the hydrochloric acid, or active pepsin, 44 of its amino acids are cleaved from the molecule, resulting in pepsin. If a chief cell produced active pepsin, it would digest the chief cell's own internal proteins. So secreting pepsinogen protects itself. G cells are the endocrine cells of the gastric gland, and they secrete the hormone gastrin into the blood. Gastrin stimulates gastric secretions and gastric motility. Gastric motility refers to the muscular contractions of the stomach that mix and churn food and then propel it toward the duodenum. Swallowing food actually stimulates a reflex in the stomach that causes it to resist being stretched. I know this sounds a bit counterintuitive because the food's coming and we need to fit it in there. But this doesn't last, and the stomach relaxes so it can receive the bolus. This is called the receptive relaxation response. Kind of like the heart, the stomach's muscularis externa has pacemaker cells that set a rhythm of peristaltic contractions, squeezing contents from the middle of the stomach's body toward the antrum and pylorus. These contractions churn and mix the food so it encounters as much gastric juice as possible. The churning and mixing promote mechanical and chemical digestion. The muscularis in the stomach's antrum is really strong, and it acts as an antral pump. Since the antrum is close to the duodenum, the strong contractions break up as much of the chyme as possible so it's ready to enter the small intestine. Successive waves of contractions in the stomach's muscularis squeeze the chyme back and forth, mixing and chopping it up until the particles are less than 7 millimeters in size. Even then, only about 3 milliliters of chyme passes through the pyloric sphincter and into the duodenum at a time. Typically, a meal takes about 4 hours to fully leave the stomach. The stomach tissue is protected from its own secretions by the thick alkaline mucus lining the lumen and the tight junctions between epithelial cells. Epithelial cells of the stomach last only as much as 6 days or so before they're shed into the lumen and replaced with new cells. By the time the contents of the bolus leave the stomach, they have been converted to that soupy liquid called chyme. The stomach does a few different things to facilitate the digestive process. It mechanically digests the bolus we swallowed by mixing and churning it up. It secretes gastric juice to chemically digest the bolus. It stores the bolus until the duodenum is ready for it, and it propels its contents distally into the duodenum. This gastric function is regulated in 3 phases: the cephalic phase, the gastric phase, and the intestinal phase. These phases are not chronological, and they overlap with one another, happening simultaneously. Let's start with the cephalic phase. It's called cephalic because it's in your head. I'm not saying it's not real. I'm saying that your brain is activating your stomach based on what you are seeing, smelling, tasting, or even thinking about food. Before any food is even swallowed, the stomach starts activating. The sensations and thoughts send nerve signals to the hypothalamus, which then sends signals to the medulla oblongata, where the vagus nerve has its nucleus. Motor signals travel on the vagus nerve to the stomach and stimulate the parietal cells to secrete the precursors to hydrochloric acid and the G cells to secrete the hormone gastrin. This prepares the stomach to receive the food you expect to be swallowing soon. The cephalic phase accounts for about 40% of gastric acid secretion. Next is the gastric phase, which accounts for about 65% of all gastric secretion. This is the phase that the stomach itself regulates, hence the term gastric. In the gastric phase, gastric secretion is activated by the physical presence of the bolus stretching the walls of the stomach, and the peptides and amino acids from partially digested proteins raising the pH of the stomach. Let's start with the stretch reflexes of the stomach. There are two related to gastric secretion during the gastric phase. One utilizes the network of enteric nerves in the stomach's wall, called the myenteric plexus. The myenteric reflex is called the short reflex because the neurons stimulated by the stretch send their nerve signals locally along parasympathetic neurons that stimulate the stomach's cells. The short reflex arc doesn't leave the stomach. The long reflex sends sensory signals via the vagus nerve, which sends parasympathetic motor signals also on the vagus nerve back to the stomach. Since the vagus nerve is both the sensory and motor component of the long reflex, it's called a vagovagal response. Each of these reflexes results in the release of acetylcholine to the stomach cells. The presence of food in the stomach stimulates enteroendocrine cells of the gastric glands. Enteroendocrine means the cells of the GI tract that secrete hormones. These secrete histamine, and the enteroendocrine G cells of the pyloric glands secrete gastrin. Histamine, gastrin, and acetylcholine all stimulate the stomach's parietal cells to secrete hydrochloric acid and intrinsic factor. Gastrin and acetylcholine stimulate chief cells to secrete the zymogen pepsinogen, which is activated into the protein digesting enzyme pepsin by hydrochloric acid and already existing pepsin in the stomach cavity. Acetylcholine also stimulates mucus secretion to protect the stomach's lining from acids and digestive enzymes. The small peptides and amino acids of partially digested proteins keep the pH of gastric juice above 2.0 and also stimulate G cells to secrete gastrin. As we digest more and more proteins with pepsin, the breakdown products continue to stimulate more and more gastrin secretion. It's a positive feedback loop. However, eventually the peptides and amino acids leave the stomach for the duodenum, causing the pH to fall. When it gets below 2.0, the parietal cells and G cells are inhibited so it doesn't get too acidic. That's a negative feedback loop. The last phase is the intestinal phase. As the ingested bolus and fluids are converted to chyme, they are eventually propelled from the stomach to the first part of the small intestine, the duodenum. The duodenum's lumen doesn't have the volume of the stomach cavity, so the stomach can't empty all at once. So the duodenum utilizes hormonal and nervous reflexes to regulate how quickly the stomach empties its contents. And it's not just about slowing the stomach down. At first, the duodenum promotes gastric secretion. When the chyme first enters the duodenum and stretches its wall, the long vagovagal reflex is enhanced. The peptides and amino acids stimulate the duodenal G cells to secrete intestinal gastrin, which targets the stomach, promoting gastric secretion. Now, the duodenum does not like an acidic environment, so eventually the acid entering from the stomach, plus the partially digested fats, stimulate an inhibitory reflex called the enterogastric reflex. This reflex targets the stomach, slowing down gastric emptying. The duodenum also releases the hormones secretin and cholecystokinin, which decreases the contractions of the stomach's muscularis externa and stimulates the pyloric sphincter to contract. When that pyloric sphincter is contracted, stomach contents can't move into the duodenum. Secretin and cholecystokinin also stimulate the gallbladder and pancreas, which aid digestion in the duodenum, but we're going to talk about that later. Chyme in the duodenum means the jejunum and ileum are about to absorb a lot of nutrients in the bloodstream, including glucose. So the duodenum's enteroendocrine cells secrete the hormone glucose-dependent insulin-tropic peptide, or GIP. GIP targets the pancreatic islets to secrete insulin in anticipation of a rise in blood sugar. Okay, so now let's talk more specifically about the stomach's gastric secretions. There is a lot of hydrochloric acid in gastric juice, and it can bring the pH inside the stomach down as low as 0.8. Let's discuss how the stomach produces hydrochloric acid. So now you're going to have to recall that hydrochloric acid is one ion of hydrogen and one ion of chloride held together by an ionic bond. HCl is its chemical formula. The reactions necessary to make hydrochloric acid take place in the stomach's parietal cells, which contain the enzyme carbonic anhydrase. You may remember me discussing the following reaction in the respiratory episodes, which are episodes 51 and 52. Carbonic anhydrase catalyzes a reaction between water, H2O, and carbon dioxide, CO2, to form carbonic acid, H2CO3. Carbonic acid dissociates into an ion of bicarbonate, which is HCO3 with a negative charge of -1, so HCO3-, and hydrogen, H+. Since hydrogen only has one proton and one electron, if it loses an electron to become an ion, it's essentially just a proton. The parietal cell returns the bicarbonate ion to the blood in exchange for a chloride ion, which is then delivered to the stomach cavity. Active transport pump proteins in the parietal cell, called hydrogen ion potassium ion ATPase pumps, pump the hydrogen ion, or proton, into the stomach cavity, while a potassium ion is pumped into the parietal cell cytoplasm. The hydrogen ions and the chloride ions bond in the stomach cavity to form hydrochloric acid. You may have heard of antacid medications like Nexium or Zantac. These are called proton pump inhibitors. Now you know how they work. They inhibit the pump protein that pumps protons, or hydrogen ions, into the stomach cavity, therefore making it very difficult to make a lot of hydrochloric acid, decreasing the stomach acid and giving people relief when their stomach acid levels are too high, bringing their pH too low. We'll talk more about what that can mean a little bit later on. In addition to activating pepsin and gastric lipase, hydrochloric acid helps break down food, forming chyme, aids in iron absorption, and destroys pathogens that we consume. Pepsin, the protein digesting enzyme we discussed earlier, is another gastric secretion. The stomach secretes gastric lipase, which digests some of the fat in our diet. Most of the fat is digested in the small intestine, however. The parietal cells of the stomach are the only cells of the body that secrete intrinsic factor. Even though vitamin B12 is absorbed in the small intestine, its absorption requires intrinsic factor to bind vitamin B12. Vitamin B12 is essential for the synthesis of hemoglobin. Without hemoglobin, as we know from previous episodes, we can't carry oxygen and cells can't synthesize ATP. Without intrinsic factor, a vitamin B12 deficiency occurs called pernicious anemia. I mentioned that a little bit earlier in the episode. The symptoms include fatigue, pale skin, shortness of breath, weakness, dizziness, and numbness and tingling in the hands and feet. Pernicious anemia is typically caused by an autoimmune disease that attacks the parietal cells. The stomach's enteroendocrine cells secrete hormones into the blood plasma and paracrines that act locally. Some of them I mentioned earlier, like cholecystokinin, gastric inhibitory peptide, and secretin. These are protein-based chemical messengers that are also produced by neurons in the central nervous system. So they're called gut-brain peptides. They're both produced in the gut and in the central nervous system. Other gut-brain peptides are substance P, vasoactive intestinal peptide, or VIP, and neuropeptide Y, or NPY. These mostly function in appetite regulation and energy balance. And I'm going to cover that in subsequent episodes. So I think we should wrap up this episode by talking about some of the things that go wrong in the stomach. And we're going to start with vomiting or throwing up. Vomiting is when stomach and or intestinal contents are expelled from the digestive tract by way of the mouth. it can be stimulated by several different things. And hopefully listening to this show isn't one of them. It is a reflex that has its integrating center in the medulla oblongata. Since the fancy word for vomiting is emesis, that integrating center is called the emetic center. Among the potential stimuli that activate the emetic center are trauma to the abdominal or pelvic organs, overstretching of the stomach or duodenum, alcohol, particularly intense pain, and bacterial toxins that we consume, like if you ate something that had gone bad or was infected with a Salmonella bacterium. Since the emetic center is in the central nervous system, vomiting can also be stimulated by seeing something, smelling something, tasting something, or even thinking about something that makes you nauseous. Right? Nausea is essentially an upset stomach. Before vomiting, there is usually nausea and a widening of the thoracic cage with contractions of the abdominal muscle. The muscularis externa muscles of the stomach and duodenum contract while the lower esophageal sphincter relaxes. Vomiting doesn't usually happen without warning. The first contractions typically only get the chyme partway up the esophagus before it falls back down to the stomach. This is called retching. As retching continues, the abdominal contractions get stronger and stronger, and the upper esophageal sphincter opens in response to an increase in pressure in the thoracic cavity. Finally, the combination of all those muscle contractions, abdominal skeletal muscles and GI smooth muscle, the chyme is ejected from the tract out the mouth. If you have an illness that is causing you to vomit excessively, there is a risk of dehydration, electrolyte imbalances, a change in the pH of body fluids, and acid-induced erosion of the esophageal lining and tooth enamel. Okay, so let's talk a little bit about some of the more common pathologies affecting the stomach. One of the most common things you'll see is gastroesophageal reflux disease, or GERD, G-E-R-D. This occurs when the lower esophageal sphincter, which remember is the muscle that normally prevents stomach acids from going backwards into the esophagus, becomes weakened or dysfunctional. When something goes backwards in a tract, we typically call that regurg, or in this case, reflux. We don't want the acids going into the esophagus because it doesn't have the protective lining that the stomach has. Factors such as hiatal hernia, which I mentioned earlier, obesity, pregnancy, smoking, and consumption of certain foods like real spicy foods or fatty foods, caffeine, chocolate, they can all contribute to this condition. When you have GERD, you typically experience a burning sensation in the chest, which we refer to as heartburn, because the esophagus runs down posterior to the heart. And if the lining of the esophagus is getting burned from the hydrochloric acid in gastric juice that's up in the esophagus where it's not supposed to be, you're going to get this burning that feels like pain in your heart. And so people call it heartburn. You might also get difficulty swallowing because there might be some irritation to that lining and maybe inflammation. Some individuals can get a chronic cough, or they can get a sore throat. And sometimes you feel like there's a lump in your throat from the inflammation. The sore throat is because the acid is getting so high that now it might be in the pharynx. The management of GERD typically involves lifestyle modifications such as losing weight, elevating the head when you're in bed, and avoiding triggers like the spicy foods and things like that we mentioned earlier. I mentioned the medications, the proton pump inhibitors, other antacids that you can take like Tums or Rolaids or things like that where they just neutralize the acid in your stomach. Overall, GERD has a good prognosis when it's appropriately managed, but if it's left untreated, it can lead to complications such as esophagitis, strictures, which means that the esophagus is constricting, Barrett's esophagus, or even esophageal cancer. Another thing is gastritis, which refers to inflammation of the stomach lining and can be caused by various factors. The most common cause is Helicobacter pylori infections. But excessive alcohol consumption, prolonged use of nonsteroidal anti-inflammatory drugs like ibuprofen, aspirin, and naproxen, stress, autoimmune conditions, and other bacterial infections can also cause gastritis. Patients often present with upper abdominal pain or discomfort, nausea, vomiting, bloating, and a loss of appetite. And in some cases, gastritis may lead to bleeding, which can manifest as vomiting blood or having black stools. When you defecate, the feces that comes out has blood that has had to go through your entire digestive tract, and that blood tends to come out real black. Treatment of gastritis generally focuses on eradicating the H. pylori infection with antibiotics combined with acid-suppressing medications such as the ones we mentioned earlier, the proton pump inhibitors. Also, you want to ease up on the use of NSAID pain relievers, nonsteroidal anti-inflammatory drugs again, and avoid alcohol and irritating foods. In more severe situations, hospitalization and blood transfusions may be necessary if significant bleeding took place. For gastritis, the prognosis is usually favorable when treated appropriately. However, if the condition becomes chronic or remains untreated, it may increase the risk of developing peptic ulcers or gastric atrophy, meaning the stomach starts to shrink. Speaking of peptic ulcers, these are when you have open sores that develop in the inner lining of the stomach or the upper part of the small intestine. The primary cause is that Helicobacter pylori infection and the long-term NSAID use, like we said earlier, stress, excessive acid, a lot of the similar triggers as we saw with gastritis. Individuals with peptic ulcers often experience a burning, gnawing pain in the stomach area, typically occurring between meals or during the night. Other signs include nausea, vomiting, bloating, reduced appetite, and in cases of bleeding, vomiting blood or passing black stools. So a lot of the symptoms are very similar among the different gastric pathologies. Like before, treatment involves getting rid of the bacterial infection, reducing stomach acid, discontinuing the NSAID use. Those are the things that you want to do. Severe ulcers may require surgical intervention in case of perforation of the stomach, or if there's excessive bleeding, or there becomes an obstruction in the gastrointestinal tract. Again, the outlook's pretty good with peptic ulcers, as long as they're treated appropriately. So these conditions, GERD, gastritis, peptic ulcers, they're interconnected by their impact on the digestive tract and often share common causes, like we mentioned earlier. With early diagnosis and appropriate treatment, patients typically have favorable prognoses, although long-term complications can occur if you don't stay on top of it and treat it the way you're supposed to. All right, so as I suspected, I think the stomach has enough information for one episode. In the next episode, we'll get into the small intestine, the abdominal accessory organs of digestion like the liver, pancreas, and gallbladder, and we'll talk about the absorption of all the different nutrients that we consume. Once again, thank you so much to my guest, Dr. Jill, who you can follow on TikTok and Instagram at my.anatomy.teacher. Check the show notes for links. And thank you for listening. I hope this podcast is helping you get your B or better in A&P. Good luck. I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media. Don't forget to check out my Instagram account and my YouTube channel, both called Student Help for AP. I'm posting a lot of stuff on there right now that you can watch and that will hopefully really help you understand this A&P stuff. Very special thank you out to my family, Bucks County Community College, and McGraw-Hill Education, where you can find my tutor video-based textbook alternative Anatomy and Physiology digital suite, already being used by several colleges and universities throughout the United States.